Good morning, everybody, and welcome to our webinar. That is a co-hosted webinar together with me and Lars, who's sitting behind me, as you can see. And we're happy to have lots of participants here from the other side of the small pond. So Aaron is joining us from Vancouver, so I had to drag him up from his bedside. And to be assured that the whole seminar is about the COVID-19, so I will just show you here that we have prepared ourselves with a ruler here, so you can see that Lars is social distancing from me, exactly 2 meters, so we are safe, and we have washed our hands and used some alcohol, not on the inside, but on the outside. So with that, we will start off this seminar. So everybody, you're most welcome to join here today, and I'm so happy to have so many participants coming in. A few housekeeping items. The webinar is in broadcast mode for all, which means that you will be on mute, except for us in the panel, the panel or the speakers. And we will unmute you in the final session with the Q&A, and we'll pick up Q&As from the chat opportunity or the Q&A that you have in the GoToWebinar panel, as you can try it out yourself, and we will monitoring this all through the webinar, but we will not take up any questions between the different presentations, but rather save that to the last thing in this broadcast. And as I said, it will also be recorded. And then this is good. There you go. So on the agenda for today, we have an introduction that will be starting off with Lars, who will be presenting. So we will shift chairs, he and me, and so I will be sitting behind him instead. Then we will move over to me, and I will have a quick walkthrough of COVID-19, especially FHIR data, and introduce you to also some notions about graph databases and other things, to then hand over to David, and hopefully we will also have Harold on board, but it will be David who will be doing the presentation, but Harold will join us also for the panel discussion to speak about HL7 and FHIR, and specifically how they have worked on expanding their RDF statements and stuff to cover the COVID-19 vocabularies and such. Then I'm happy to, yeah.
David is having troubles getting in. I need to connect with you on Skype or something on that. So.
Okay, I will. Yeah. Good morning, Harold. By the way,
apologies.
I will hand over to Aaron, who happily we have been able to wake up this early morning crawl, and he will speak specifically on schema.org, since that vocabulary is widely used, and it's efforts to cover COVID-19 and the corona pandemic attributions and stuff, and he will speak about that. Finally, we will have Frederick, who will speak about privacy and COVID-19, but more specifically about my data and an initiative they have about personal health. And then the final statement will be the Q&A. So with further ado, I will share now with Lars. So Lars.
Thank you. Dear friends, I'm really honored to be a part of this webinar today, together with Frederick. And we host it from AI Innovation in Sweden and SweLife, two national projects that is focusing on how to make meaningful use of data. I put up those two images because when I looked at the coronavirus, it was a round thing in the world also. And sometimes I thought it looked like a nuclear war has been there. I also think that it's important for us all to focus on the need for data today to complete the web for prediction and protection. We have never before had so much data that we are producing at the moment. We have never before had so difficult to understand what it talks about, and never before so hard to know who said what. Never before. So I think this initiative we are doing here and in the rest of the world is so important for us all to really take the benefits of what we can do together. So with that, I will leave back to Fredrik and we will start this webinar. Thank you.
We're talking about talking heads here, so that's good. So with further ado, I'll now move over. So as Lars just stated, well, the COVID-19 pandemic is a true wicked problem. And when at Christmas we got some notions about, incoming, news stories from China, none of us could realize what the this spring or early winter and spring would leave us with. And now we have a pandemic that we have never seen the likes before. Obviously, this is the frontline heroes in terms of the response to the COVID-19, and we get daily reports from the hospitals across the globe about taking care of these patients, and especially how tricky it is because this disease is lethal and deadly, as we all know, and it has widespread. So we should all applaud their efforts that they are undertaking on a global scale. Also, remember that we have now learned a new term, which is epidemiologist, which is very hard to say, but they are in the center of all this. So each and every country have their hero in terms of an epidemiologist. But we all remember our dear Hans, who was, instrumental in the last pandemic that we had in terms of the Ebola virus. And today, since we are going to speak about the quality and value of data, I think that responds and resonates quite well in terms of factfulness, because we're talking about facts. How do we get good data so that we can make good decision making, policies, and different measures and means to cover this pandemic outbreak? I will move over to a discussion about FHIR, and FHIR was initiated within the community of people working within life sciences and healthcare informatics, and they wanted to have opportunities to share their data so that the different clinical research and studies and data sets could be fairly shared amongst the different researchers. So they came up with these very simple set of data principles, which states in the first, data should be findable, and that means we need to have persistent, unique identifiers. Obviously, we'll have to have really good, rich metadata. This metadata needs to be indexed and put into repositories, and always keep the identifiers together with the metadata. The second one is accessibility, or accessible. So we need to lean upon open standards and standardization of protocols and free protocols to share data. Obviously, when we speak about health data or that domain, it doesn't mean that open should be that anybody could tap into the data, but there should be means and ways to cover those branches and so forth. And obviously as well, the metadata has always to be in the front line. Then we come to the notion of interoperability, and there are several ways of interoperability. We have systemic interoperability, which is the technical and the semantic interoperability, but we have organizational interoperability and interoperability, whereas we have policies and means to coordinate between different agencies and institutions. But in this case, we are referring very much to vocabularies or ways and means to describe and define the things we are speaking about, which in sum up as being vocabularies. And these vocabularies, as we all know them, everybody who's been working within healthcare or life sciences, we have lots of different vocabularies like SNOMED CD, MESH, UMLS, ICD-10 or 11, and so forth. So the codification of your information and classification of information have to follow a line with these vocabularies. The vocabularies in themselves, they have to be open and share the FHIR principles. In this, we get opportunities when we have shared metadata, unique identifiers, and we also have shared vocabularies to define and describe the resource descriptions of any data point that we have. In this case, we are also able to link these data sets, or as in Tim Berners-Lee's perspective, the linked data or semantic web, if you will. And the last point, obviously, is reusable, because it's useless to have all this data and it's hidden or locked in different information silos, or with very obscure schemas or databases which are undecipherable for the end user. So we need to have means for make things reusable. There should also be aligned usage licenses for the data sets that we are provisioning in this space. Provenance is in the forefront, because we need to be assured who has done the data collection, to which means has it been collected, who is responsible, and who will be granting that this data is valid as a data set to work on. And in that, we need to lean upon community standards. In this time of day, we have obvious data challenges. The data challenges refer to, in the middle, obviously the virus, and the virus has different genomes and DNAs, and this is the amazing thing with, compared to the Spanish flu that we had, which was a deadly disease 100 years ago, is that within the time span of less than 2 weeks, huge computer centers were able to codify the whole DNA sequencing of the virus, which is never happened before. But we also have lots of people engaged in this, the citizens, the people who are becoming patients. There's an ongoing effort in terms of R&D, building new treatments, putting forward vaccines and so forth. There's an immense amount of knowledge created in this space. Knowledge in this case is experiences, studies, articles, and what have you. We need to consider policy making, and we have the WHO, who are the founding regulatory domain for the global domain, and all countries have followed the medicine regulations. But in the end, we have local instantiations of how the policymakers have taken on the pandemic problem. Then we have us as people. Are we coherent to the stated restrictions or facts, how we should behave, as me and Lars, but also about the data and how the data is collected. So just to take you into one of the domains, as in this case the R&D, there are a set of obvious category, high-level categories of treatments that is going on. Obviously, there's prevention of the infection, which means the high speed as we have now to develop new vaccines, or to post-exposure prophylactic therapy for high-risk individuals. We have the viral inhabitation with antiviral therapies or plasma-derived therapies, or we have immune modulation. This is the ongoing processes. This means that in the terms of the multiple treatments, they have to fit together. On one side, we have the the high-risk patients. We have the patients who are being affected by the SARS-CoV-2, and we have healthcare providers. And there is a curve on how severe this disease is getting for you. And in the other side, we have how we can develop vaccines for the populations, or when we reach the famous new word that everybody has learned, herd immunity. I have never heard that before. The other thing is that we know from now experience that after people have survived the COVID-19, there are huge clinical needs post the COVID-19 for people who have, so they have problems for heart failures and many other things. So this means that we have to, develop new practices and new treatments to cover up for this as well. That said, leaves us into a completely new space. And as stated here by Emma, who's the CEO of Glasgow, that it usually takes a decade to develop these kind of treatments and vaccines, whereas now we're talking about 18 months. As we speak, there are 625 clinical trials ongoing, 150 products, where many of them are also investigated by the products that has been granted by FDA or acknowledged by FDA and so forth, where we're trying out, to find means to cover this. And the challenge in all this is the parallelism, because there's so many ongoing projects and the data is not shared according to the FHIR data principles in many cases, which makes it very, very difficult. Another notion here is that we have learned now, all the citizens and us as patients, to become mathematicians. We know that the statistical courses in university were the most boring ones, but now every day we'll tune in to the news stories about different mathematical models to cover the viral reproduction R, the famous R. So if the R equals less than 0, the virus will go away or be covered. Or if it's a higher reproduction, viral reproduction, as it is now with the COVID-19, we have 2.5 up to 3 in the R statement. All countries across are trying to flattening the curve, using different means and measures to do so, and we have lots of different ways of aggregating the data from the central resources to see how many casualties we have from corona, how many people who are in ICU, and so forth. That is a daily update. So this is from Google, and we have the similar one from Bing doing the same, and we have a couple of others as well, and they are giving you a notion of where we are going, and you can see the curve here going up and down and so forth. So we are now becoming data analysts. The problem is that, well, when you do this modulation with the mathematical models, there might be some problems. And as in this case, the famous Imperial College publication, where they made some assumptions with a huge curve for the UK, which made them shift their different policies to taking care of the coronavirus, which means that if we get bad data or bad structured data and we're not using it in a good manner, that means that it will be reflected in the ways we prepare for the modeling of different occasions. And I would say I'm an informatics person, so I'm not within healthcare. I wish I would. The other thing is, as I was mentioning here about coherence and mobility, every day we get the opportunity to get mobility reports from, for instance, this one is from Google, where we can see how we as individuals are actually moving around. And this is data points that we were never able to cover before. And we can see how this has been categorized from Google, saying, well, how much we are moving around, whether we are going more to the parks. As we can see, this is the stats from Swedish cases, which means that we like to go out in the nature. So we can follow day by day what's going on in these data heavy times. But that leaves us to this case, which is the privacy and of your data. So where do your health data and how do you share your health data? If you live in China, for instance, this is a picture of the famous app that they have to give you red or yellow, whether if you are a good behaving citizen according to the Communist Party, if you're following and adhere to the rules. And we're seeing similar toolings coming out, and that is why I had the idea to bring on board my fellow friend Frederick in this presentation. And I will shift a little bit of gear here and just show you some stuff, because I think it makes sense. So bear with me. It might be some problems, but I just hope that my timeline, and Lars will have to tell me how well I'm. Yeah, 2 minutes. Yeah. So what I'm showing you here is a graph database enabled feature for data discovery, which are leaning upon FHIR data principles, and it has huge amounts of medical publications. And I didn't mention that, but since January, there's been 57,000 articles and medical publications and counting. 57,000 to cover this outbreak. So if I'm just searching here, for instance, for vaccine, you can see here. And then I can go down to see, well, are there any ongoing activities in terms of patents? And here I have linkages to the different schemas or the different terminologies. I can navigate here. I can get stats, and I can, further investigate this data analytic tool. I'm not, specifically targeting the tool in itself. I'm targeting that the question about sharing your data according to the FHIR principles makes it much easier, because we have so much detailed information about the data that we need to cover. And now I wonder whether my fellow friend Harold or David have been able to join the call. Harold? See, because I would like to shift, or if I need to make arrangements so that we instead.
David is the one that is prepared to present, and he's having trouble connecting. So if we can do a shift, he needs some assistance.
Okay, so Aaron, are you happy to jump in instead of David to start off with schema.org? So I'll make you two presenters. We'll keep the
presentation going while we work out those technical details.
Yeah.
Well, thank you very much, Frederick. Thank you, everyone. I'll be speaking, hopefully fairly briefly, here today on some changes. Some changes to schema.org in response to COVID-19, specifically looking at 3 things. Changes to vocabulary around events and event processing. This because you'll recall, especially in the early days of the pandemic, virtually every scheduled in-person event disappeared, many of those moving online. The generation of a new special announcement type, a subtype of creative work, which is a type used for expressing structured data about special announcements, obviously in this case centered around health emergencies. And finally, the representation of a CDC PMD record in schema.org formats so that hospitals could, should they so desire, upload this information and make it accessible to data consumers by annotating web pages with this record. So first, events, new support for virtual events. Schema.org has long labored under not having really good vocabulary for online events. And this came to a fore with the pandemic because so many in-person events were canceled, many of these events online, but schema.org had no way of saying this event takes place in a virtual location or this event is online rather than in person, or any combination of those two. So they quickly developed some new vocabulary, often based on some very long-standing discussions, sometimes year-long discussions. So a new type that can be used as a target for location, in addition to place, which expects a physical location, is virtual location. A new enumeration, that is a list of values that can be used in association with an event. These a new enumeration called event attendance mode enumeration, by which event organizers can say what sort of event this is, an online event, an offline event, or a mixed attendance event, where there is both online and offline attendance. And then one new event status type enumeration, joining things like events canceled, events postponed, and events rescheduled, is the new type, event moved online, for the many conferences and symposiums and other events that were to take place in person, but have since been moved online. I'm not sure if any of you have been following the Knowledge Graph conference over the last couple of days, but that is an example of such an event that was originally to take place in New York City, but has since been moved online. There have been some event markup, I should note, for those not necessarily that familiar with schema.org. One of the benefits of using it for webmasters is that it generates special rich results, that is enhanced search results for events, often providing things like dates and titles, and in the event of physical events where those events take place, we've started to see some changes in the search engine result pages as a result of this markup. In particular, you'll see here this CIKM conference, which is marked as an offline event. You will see this no in-person attendance flag, and as well in the knowledge panel representation of this. And I've been seeing a lot of, I'm not sure whether this is sticky, but for location, I've seen Earth and planet Earth appear here. So it does, the schemas do seem to be making their way into Google markup. Probably of more interest to participants here, special announcement. This is a simple type of creative work, date stamp with textual information, providing web links and other structured data that allows a webmaster to promulgate some sort of special announcement. It represents, as the schema says, an information update made by a locally oriented organization, especially schools, pharmacies, healthcare providers, government groups, police, local government. However, just to be clear, the information updates may be at a locally oriented level, but certainly a special announcement can be used at any altitude. And as we'll see, many countries have published special announcements at the national government level. What does special announcement consist of? A new type, a subtype of creative work, special announcement. In order to support some of the properties that are added to special announcement, there are new places developed, COVID testing facility and school district. We'll see their use in a moment. And Google and Bing recognize support for the new vocabulary right out of the box. Normally, it often takes search engines some time to say, yes, we like this schema and we're going to start using it. It was virtually simultaneously with the announcement of the schema itself. Properties by expected type, and one of the reasons that I think it's easiest to look at the properties of special announcement this way is that the bulk of them expect a schema.org type, their way of saying range of either URL or web content. So while special announcement is a structured data type, most of the properties that that special announcement has are basically information pointers. So disease prevention information, getting tested information, public transport closures, quarantine guidelines, school closures, travel bans, and news updates. All of these basically point to some other page. So the use of these properties by the search engines is to say, hey, if you're looking for getting tested information for the authority that I'm representing, you can find it at this URL. It could also point to some other piece of web content. Think of web content as meaning web page, but typically this is going to be a URL value. A couple of more structured properties. There is a disease spread statistics property, which, as the name suggests, is a mechanism for expressing spread statistics for that locale, and accepts a wider variety of types, including data set. So you could say special announcement, I have information about special disease spread statistics, and you can find them at this data set, which would then also expose that data set to data set search in Google. There's a data feed, or the URL can be used for a web feed. So special announcements are to a certain degree expected to be kept continually updated. So this mechanism supports that. There's a category property that can take a physical activity category. An announcement location, pretty important again to know for the search engines and other integrators to know what sort of coverage this special announcement, what sort of spatial coverage this has. So you could say this announcement location is for, you know, the town hall in Vancouver. There's also a note within that, because it's a creative work, you can also use spatial coverage. So in creative works and schema.org, you can be very specific about the area to which a given creative work applies. Your standard date fields plus now date posted, so you can keep track of the provenance time-wise. And then a recently added property, government benefits info, which expects a type of government service. So when there are government benefits being offered in response to the pandemic for a particular governing region, they can be expressed here in structured data. I'll note too that most of this vocabulary came in with schema.org 7.0, but I believe they then did some micro releases up to 7.04 to add what they discovered were some gaps in the vocabulary. For example, the government benefits info is a little bit of, was added a little bit later than the main vocabulary. As I said, Bing jumped right on board, so did Google. So they were very much encouraging webmasters to use this. Subsequently, Google published this developers page on how to use the markup and gave an example of what it might look like. Since then, we're starting to see some examples in the wild. Here is the Government of Canada. Their main coronavirus disease page contains special announcement markup. If you were to look at that, it's in JSON-LD, so I just ran it through JSON-LD Playground, and pretty basic structure. As I said, most of those informational links you can see here, simply saying, oh, you want quarantine guidelines, go to this URI. And you can see that government benefits info as a type of government service has more structure to it, where that in turn can be expressed with a bit more depth in the search engines, should they choose to take it that way. And if you were to run this page through Google's rich results test, their new main structured data testing tool, you can see that it is indeed eligible for rich results. They yet have no preview for special announcement, but they do the validation. And the same is true of the older, but still running Google structured data testing tool. The UK was one of the first to adopt a special announcement, even making a point of announcing the fact that they had used a special announcement. Kudos to them for, I think, being the first in the block. And it's been running for a while now, so you can start to see some of the relationships in search and the use of a special announcement. Here you see this general query, Great Britain coronavirus. I had to do that because I don't have a UK proxy and I'm in Canada, wanted to get UK results. But you can see that it's giving this panel of general information, testing, quarantine, travel, which align very nicely with many of the special announcement categories. And if you were to say, look at that closures and event, that link to public transport is the same as the public transport closures info URL declared in special announcement for that main UK coronavirus webpage. These sort of search results are always going to be a mix of information pulled from special announcement, from regular web crawling and parsing and indexing done by Google. Quite a number of these pages. There's another more established schema FAQ page, which, as the name suggests, gives questions and answers, obviously very useful in terms of health questions, so quite a number of those appearing in the search results as well. So special announcement very much augmenting and adding to what Google and Bing already have in their indexes. In the last couple of weeks, some further tools from Google. They've provided a mechanism in Google Search Console, previously known as Google Webmaster Tools, by which webmasters can submit a special announcement without requiring the need for a markup. For local businesses, Google's main portal for local business, Google My Business, also supports the generation of a special announcement and other COVID-19 related data through their forums interface. This obviously the big importance there for Google My Business is that it provides a way of local businesses to tell Google of special hours in relation to store closures. And now too, just a couple of days ago, they started reporting on special announcements in Search Console, giving enhancement reports. This is for any sort of rich result. It tells you what's working, what's not, what has warnings, what's been rejected, as well as performance, how people are looking for and ingesting information provided through special announcement. And finally, mid-April, the White House Office of Science and Technology Policy actually published this news article encouraging chief information officers to discussing the special announcement and encouraging CIOs to update their websites with these new schema tags, which will help Americans, obviously, White House, US facing, find the latest special public health announcements and information through their search engine queries. So I think pretty plausibly the first time the schema.org has been mentioned by the White House. And then finally, schema.org rapidly developed a CDC PMD record. These are CDC-defined data fields for hospital reporting, and the purpose of the definition was to provide a standards-based representation that can be used to encode and exchange records that correspond to the CDC format. Nothing by the way, PMD record stands for Patient Module Denominator Record, a CDC format. So basically, what schema.org has done here is represent that format in a schema.org fashion, as written in schema.org, intended to be one-to-one with the original representation and round-trippable. So both in interest of expediency and in terms of retaining that one-to-one relationship, schema.org did not do anything fancy here, but tried as much as possible to replicate the CDC record in schema.org format. This is what the schema looks for from CDC. Pretty standard stuff. You've got fields, values, requirements, and descriptions, and you'll see pretty much exactly the same fields in schema.org, except they've all been prefaced with CVD to avoid name collisions. The other difference too is that constraints such as optional or required or range of values, schema.org has no notion of constraints, so they've only been captured as nodes within the schema. There's no way of representing that in schema.org structured data or to enforce that. And these are the sort of fields that are represented in a CDC record, things like number of hospital inpatient beds compared to how many are occupied, how many people, how many patients died, all of that sort of detailed hospital reporting, in this case for COVID-19 specifically. One of the interesting things about this particular type is that in general, schema.org is used to support the ingestion of information by the search engines. However, this format is being published specifically to support public health organizations and research. And they say explicitly there's no assumption that data encoded in the schema should be necessarily published on the public web, nor should that it would be used by search engines. So schema.org here saying we're making this schema available, but there's little to no expectation that search engines are actually going to make use of this. I'll note too that Bing in its ingestion of special announcement information said that it may use this information when it comes from official sources to generate statistics. I don't know, if you go to bing.com /COVID-19, you can see COVID statistics there. Very much doubt most of any of that is coming from special announcement, but it is conceivable, especially in terms of the data provided values for disease spread statistics. It is possible that search engines or other data consumers could harvest that information and reproduce it in other ways. I'll just make a final note on the CDC BMD record, and I just verified this with Dan Brickley of schema.org, that yes, it is very US-centric. That is in part because it was requested that they build a schema, and that schema.org is by no means against supporting other such schemas should a use case arise and someone make a case for it. So no, a special case why only the US-centric CDC record was supported at this time. Simply, it was the first to come to light. Frederick will be sharing the URLs of this presentation after, so I won't be going through any of these, but just to note that there are references in this deck, and anyone feel free to reach out to me with any questions in regard to this. You can find me on my site or almost always on Twitter. Thank you very much.
Okay, so I'm David Booth, and I am working with both the Mayo Clinic and Johns Hopkins University on a project right now that's called COVID-19 on FHIR. My background is, well, computer science, and I've been involved with semantic web technology and RDF for quite a number of years, and applying it to healthcare and life sciences for the past 10 years or so. Next slide, please. Oh, and I should also mention that I'm actually not the main person who's been doing this work. Gojun Jang at Mayo Clinic is really the primary person, but I'll be presenting today, so it's possible there will be questions that I won't be able to answer, but if so, we can follow up later. Next slide, please. Okay, great. So several weeks ago, the Allen Institute, which is Allen Brain Institute, funded by, I think it was funded by Paul Allen originally from Microsoft fame, released a data set of literature that they called COVID-19. And it's literature related to COVID-19. So a whole bunch of scientific articles, and not all of them are directly about COVID-19. Some are about other coronaviruses, but they seemed closely enough related that they would probably be relevant to researchers who were doing research on COVID-19. So the Allen Institute released this, actually, next slide, please, released this data set called CORD19 in the hope that it would be useful to a lot of researchers around the world. And there are, in this data set, there are actually, these numbers are a little bit old. They're continually updating. This says that there are about 29,000 full text articles. I believe there are more than that now. And there's a whole lot of abstracts that don't necessarily include full text articles. This data set, due to the licensing restrictions of the original papers, the data set has multiple licensing versions. So you can download different versions of the data set depending on the license that, that you are using it under. So that's what those links are there. Next slide. So when we saw this data set released by the Allen Institute, we thought about, hey, maybe we could make this useful by putting it into a semantic web friendly representation, into an RDF representation. And we had already been working for quite some time on an RDF representation for the FHIR standard produced by HL7. FHIR, which is actually FHIR, it stands for Fast Healthcare Interoperability Resources, but people pronounce it as FHIR. This is the latest HL7 standard for exchanging clinical data between hospitals or between departments or whatever. And it has been getting a lot of traction. This is the homepage for the FHIR standard. It's at a reasonable level of maturity right now, but it's still being tweaked as it goes along. And a few years ago, Harold Solbrig and I and Gojun Jang and some other people set out to add an RDF representation of this FHIR standard. Prior to having the RDF representation, the FHIR standard had a JSON representation and an XML representation only. But through a bunch of work, we got them to add, actually you can click to the next slide, got them to add an RDF representation. So this is kind of the home page for the RDF representation. So this was the kind of the hammer that we were using at the time when the CORD19 data set was released. And so we said, hey, why don't we put this CORD19 data set, represent it in FHIR RDF in case that would be useful to others. So that's the background of how this came about. Next slide. And if you're interested in the FHIR RDF representation, there's a nice tutorial that Harold Solbrig created, Harold at the Johns Hopkins University, that is available on the YosemiTeProject.org site, that gives a little demonstration for how this representation can be used to connect some clinical data to, in this example, SNOMED terminology, and use inferencing in order to make it produce interesting results. So you can take a look at that if you would like later. In fact, and if you go to the next slide. There's a little YouTube video, it's actually a 90-second video that runs through the steps of the tutorial to make sure you can follow along well. All right, next slide. Okay, so that's the background for why we put the CORD19 data set into a FHIR representation using RDF. So when we did this, we applied NLP to the abstracts and the titles that are in that data set of literature, and produced a whole bunch of semantic annotations that then went into the FHIR RDF representation. And so it recognized conditions, medications, and procedures. Now, the numbers that you see on the screen, those are old numbers. I think we now have about twice that number currently in the data set that we've produced. Next slide, please. Here's an example of the of a FHIR RDF record that has one of these semantic annotations in it. Now, the FHIR standard uses what they call resources, which are little schemas for different parts of the FHIR data. And the resource that we've used for representing this data is called the composition resource. So what you're seeing here is actually, this is, I think, is actually the JSON representation of it. So you can see the JSON hierarchy for this little schema for the composition resource. And down nested inside the section of it and down below there are some references, and those are the semantic annotations that we've added. Next slide. So another thing that we did was we took the data set, the CORD-19 data set, and we also ran it through PubTator, which is a product produced by the National Library of Medicine that will also do semantic annotations. Next slide. No, sorry, back on the previous slide. So PubTator produced a bunch of semantic annotations, which we then also inserted into FHIR RDF to make a FHIR RDF representation of those semantic annotations as well. Next slide. And then finally, LitCovid is another data set produced by the National Institute of Health, NCBI, that also has produced a curated set of literature around COVID. And so another thing that we did was we did this sort of same process, taking that body of literature, that data set, and again, applying semantic annotations to that. Next slide, please, and turning that into FHIR RDF, excuse me. So in the LitCovid data set, then these are some numbers of the semantic annotations that we added to that. So the result is that we have the CORD-19 data set that we've converted into FHIR RDF and inserted semantic annotations, and the results of the PubTator annotations and the LitCovid data set, all of which are now represented in FHIR RDF. And our hope is that that will be interesting and useful to other researchers. We know of at least one researcher within the Mayo Clinic who is already using this, but not sure about other researchers right now of who's using it. Next slide, please. So another thing we're doing is we're looking at the CEDO ontology and using. I'm actually not sure of the status of this, of whether this ontology is currently being used in the annotations. If it isn't currently being used, then we're working on it to try to get it be used. Next slide. And next slide. So another thing that is also in progress is that we've been collaborating with the EBM on FHIR, which stands for Evidence-Based Medicine on FHIR, which is interested in including evidence information into FHIR. And this, what you're seeing here is the schema for the evidence resource in FHIR, what that looks like. So we've been working with them to try to annotate things into the evidence resource as well. Next slide. So if you're interested in this work, it is all on GitHub. Here's the GitHub URL at the top. And finally, the other thing that we're doing is we started doing a weekly teleconference for anybody who is doing CORD-19 semantic annotations using the CORD-19 data set, so that we can collaborate with others and coordinate and be aware of what each other's doing etc. So we are doing that teleconference weekly on Tuesdays, 11 a.m. Boston time. And so if you're interested in that, we do the announcements on the W3C Healthcare and Life Sciences list. So you should sign up to that list if you're interested in joining that call. And so that's all I have. I'll be happy to take any questions if there's time for it. And that's it for me.
I'm here today representing MyData, Ideell Förening, which means not for profit, basically, for you non-Swedish speaking people. MyData has been around for quite some time, but it actually became an organization by the end of 2018 in Finland, which is also a not-for-profit organization. But I am running the Swedish hub for this and coordinating those efforts. And as Corona came along, there were initiatives from different companies in the network, specifically iGrant.io and AGI, who have been working on privacy questions for a long time, but from different perspectives. And we're here today to talk about MyData and present examples of the hack that we participated in. So for those that are not aware of what MyData is, it is an organization with a number of membership organizations, above 100 today. We're in 56 countries, I believe, and growing. What we are about is not only healthcare. We're actually active in all sectors, and we're trying to put the human in the middle of things and make sure that the individual is the point of integration for all personal data. So we're talking mainly personal data in this, but to make sure that we can reuse data between people and organizations, that we can actually act on the rights that have been given to us through different legislations across the world, and also make sure that we understand and can take charge again of how we share data about us. And we are trying to do this by opening up different silos across the world. And I think the healthcare, having worked in healthcare ICT since 2006, I can say that there are many silos still around, unfortunately. So therefore, it's a very grateful area to work in together with the healthcare professionals. So we've also been running specific talks since many weeks back now. That was one yesterday, and there will be one in 2 weeks. And you can go and join us at mydata.org Slack, or you can just join the calls as you see fit. We'll speak specifically about a solution later on here, but I want to point out that this is being done on a global level. So there are participants from Taiwan and Singapore and yeah, across the globe. And there are many initiatives, and you can also follow all of that, and you can enter your own work as you see fit. So when we came into this Corona thing, we did it from a social political cohesion view. We participated in the Swedish hacker crisis, and then where we came second in the category of saving lives. Then we joined the global hack and also the EU versus virus hack more on a governance from a governance viewpoint, because we think that that is actually the thing that we need to solve, the whole privacy and the fundamental rights around sharing healthcare data. We ended up in top 10 in the global hack, which we were quite happy with. In the latest EU versus virus hack, we didn't make any prominent position, but we continue to work on the solution anyway, and are quite proud of what we have done. So in this situation, we're obviously, this is her persona. We call him Eric. There's actually a female persona as well. She's called Ada, which fits well with the Göteborg section of this call. Anyways, we are all in fear of being infected, obviously. We are, most of us, in fear of being tracked too much, even in countries in Europe today, not only in other constituencies and administrative units. And we've been very constrained when it comes to the freedom of movement. We cannot travel as we want and wish, and we want to make sure that we get to do that as soon as possible and as safely as possible as well. We are doing risk scoring and alerts, which some people don't think useful. We think there will be when we have come to understand the questions that we actually need to understand. I think this will be a very powerful tool for all of us. We are very adamant about the protection of privacy that I hope you will be able to see in the solution. And this means that in most cases, all of the data is only stored locally, and only when it's shared, you always know where it's shared and how it's shared, and you can always revoke any consent or know the other legal grounds which are used for helping the authorities with their insights and governing in times of crisis. So we try to do this. There's lack of trust. We're trying to build trust for continued data altruism. And that is always the get-go and the starting point for anything that my data does. We are looking for insights, and I don't need to talk about that in this setting. I think that the health graph is there, and it's almost traceable down to the individual level fairly quickly today. And we don't see that we have the effective means today to do the. Most countries basically they're trying out, and that's good because from that we can learn. But we also need to monitor what is actually effective measures, and we're trying to do this by having as many as people as possible sharing their data for reuse. And I don't know if Lal is now live and able to speak. If not, I ask Frederick again to let him in.
He's live, and I will unmute him as soon as I just find him on the list of participants. I'm happy to have many participants. So there you
go.
Lal, can you speak up now?
Hello,
and
can you
Lal,
hear me?
Yeah, and do you want me to make you enter as well?
Yeah,
no,
yes,
I
please.
think, okay. Yeah,
no, you can present Frederick now, but when I show the demo, maybe.
Demo, then you need to be presenter. Yeah. That is true. Yes. Good.
So good evening, everyone, and thanks for the opportunity to speak in this webinar. So as Frederick pointed out, primarily we are looking at from a data privacy perspective, data regulation perspective, particularly the GDPR, and really making a system which is fully auditable. So if you look at what happened post COVID is that there's like a huge amount of apps that are being launched around, and being part of the My Data community and being the proponent of privacy and data protection regulation, we thought it's time that we also step in and really demonstrate the capabilities of a typical My Data operator in an app itself, and that's how the Data for Life was born. So as Frederick pointed out, we built the app primarily with as part of the Swedish hackathon, where we came second and so on. So what we are really doing with this app is really providing a functionality for users where they can understand the risk associated with getting infected with COVID, for example. And this particular app itself doesn't necessarily need to be for COVID. It can be for any kind of pandemic. what we essentially take is data from different sources. So at this moment of time, we have assumed that the data is primarily coming from Data for Life, where the user is entering the age and adding the historic location data from multiple data sources, etc. We are also enabling the proximity data or the contact tracing, as you might probably be aware of. We use a privacy-centric protocol called DP3T. We also allow users to connect to different healthcare authorities, for example, add a certificate where they can prove that they are, say, immunized or they are infected, and they can even perform tests, for example, where they can validate the test results with actual test authority, with exchange of credentials, for example. In our system, the whole idea itself is like really harnessing the power of data from multiple sources. So we have a bunch of standard tooling that we use. So IOM.io, which is my company, which is acting as a data operator in this case, according to the My Data principles. So we have a bunch of things that we take care of from a privacy and data protection perspective. And of course, we have also integrated other APIs like the Google, the new APIs for contact tracing from Apple and Google, for example. I'm not going to go through this. This is purely, the slide that you see on the screen is primarily for information purpose. So at this moment, I could present and demonstrate the app itself to you, if I can get the control.
Absolutely.
So do you see my screen now?
Yes.
So what you see on the left side is the user app. So in this case, I've already logged in, and on the right side is like one of the administrative dashboard. In this case, we use the healthcare authority as the as example. So let me log in. Authority.sc. Oops. Yeah. So essentially, what you see on the left side is a user app where I, as a user, is able to select like the different pandemics or any kind of say seasonal flu, etc., that could actually be around. So in this case, I've chosen COVID-19 pandemic. And as Frederick and I repeatedly pointed out, we are primarily looking at it from a privacy and data protection perspective. So I go to the My Data way down, where I, as a user, has full control of my data. So there are different areas in this section where you have clear purposes identified for the use of your personal data. There are certain things that are part of the contractual agreement. Some of the things are part of a consent-based framework. So in this case, if it is like the risk assessment that you are carrying out, you have an opportunity to really go to the lowest granularity level and allow, disallow, or allow for certain specific period of time, for example, in order for you to perform that particular purpose. So once you mark your consents, you're able to say perform certain other actions that this app provides you with. And of course, other things like being able to actually download the data for data portability, or being requesting delete data, etc., is also part of this say My Data functionality. We also provide a complete say tamper-proof audit logs, where the user is able to have full visibility into every different transaction that has actually happened with his or her data. So once these choices are made, the user is able to go to the risk analyzer, where the user is able to either do some self-screening, for example, and say mark the wellness status, and user is also able to verify the health status with different providers, for example, upload an immunity certificate, for example, or upload a test result, connect that to the test authority, etc. So these are the different data sources that this app could actually be connected to. In this case, we have not really enabled that function yet. Of course, you can enable contact tracing, location data. You can select different location history. either you can enter those things manually, or you're able to connect to different sources like a telecom operator or a Google service, etc. And once you provide all these different data, you're able to evaluate your evaluate your risk score, and you also can see the recommendation. And of course, if the recommendation is tested, you can also click to request a test directly from this app. The another beauty of this application itself is that you get notified. So let's say that you've been to certain places, or you've been in contact with a certain person who's known to be infected later. You get a notification where you get information about what could actually be the issue, and you can go back to performing a risk analysis and testing again, for example. And all this information will actually be automatically be say available as a QR code. For example, if you're, so this could be very much like a health wallet, where we think that if this situation continues, it could very well be that if you want to actually travel abroad in an airline, you might have to prove that you are immunized, or you actually have to show your health status. So this is a way to actually to exchange your health data without really say compromising on your privacy as such. So that's like the app part of it. On the right side is the authority dashboard. So this is an example where a health authority could easily add patients. Again, the focus is very much on privacy and say data minimalization, where only the information that is relevant to populate the hotspot is being taken up by the authority. So in this case, if it's a health center, they mark the person as say infected, and is able to upload the location either via a QR code from the mobile device, or it can be manually entered. And once entered, that information is available as for general population, where every information about your nearest hotspots are available, where people could also be be aware of it. And the same information is being also populated on the mobile devices as well. And the same information could also be used by authorities to make informed decisions, such as, for example, sanitizing area. So we see this kind of system really as how do we actually really harness the power of say many, and harness the power of data from individuals, with individuals consenting to sharing their data and using the data to actually take informed decision in a society's day-to-day life, such as, for example, managing the pandemic in this case. That's very much from my side.
Thank you very much. And if I can get back to presentation mode. Thank you very much, Frederick. So my data is one thing. Now you've seen an example, and just looking at the progress for this specific, as we've been talking about before, we've been in a number of hacks. We have added integration to SSI, which means self-sovereign identity, meaning decentralized identities. And that's quite an important step. Currently, we're using phone numbers for identification, as that is the only global identifier we knew about. We didn't want to use emails. So that's a good step to have SSI possibility for this app. We're also moving forward. We've sent in applications to Vinnova. The first one was denied yesterday, but we're looking to send in another one for the 29th of May to continue developing this. We've also sent in an application to Nordforsk around actual de-anonymization by using an existing DNA file to find out who is who in the database of the LifeGene project, so re-identifying that way, and how to then do share that data and do distributed machine learning on it in relationship to contagious diseases, specifically COVID-19 or coronavirus rather. We've also made applications to Next Generation Internet, which is a European initiative. for the European self-sovereign identity parts. We are looking for sponsors and trials for beta rollout. We have it in beta in Android store, and you can also try it out in test flight in iOS. Everything is openly published and open sourced, so I think we're sharing those links in this presentation in the notes. And we're of course looking, we have a wish list for the rest of 2020 and to go live, ready maybe for the second wave or whatever comes first. I think we're in a situation where we need to learn to live with this as a recurring situation, unfortunately, and that means that we have to do this in a privacy-centric way. And as I said, you can actually upload your own data to my data. I would love for you to join us somewhere in the world. If you live in a country where we don't exist today, just contact us and we'll help you out. There's a great community, not only in healthcare, but in all sectors. So thank you very much, and over to you, Frederick.
And then I'll go with the first question that was basically, going back to you, Frederick and Lal, about the technology behind your, and I think you shared quickly, Lal, about the used technology, but the question was raised by Ebba here, who was asking basically, what techniques are you using for avoiding tampering, that mentioned when you're showing the app data for life blockchain ? That was a question.
Yeah, so we use a Hyperledger Fabric-based backend for logging all consent transaction and data exchange transactions. So that's how we are enabling the tamper-proofness today.
I had a complementary question, and given that, well, in the webinar, well, at the conference I attended, well, this week, happily so, it was on the Eastern Daytime Zone, which meant that I had to go to bed at half past one every night. Very interesting timelines, but anyway, so the question I had was relating to the ongoing efforts that's stated by Tim Berners-Lee about the Solid platform and the development of the Solid set of standards where the provisioning of have a decentralized web where you separate the app from the data, so that you as a person take the ownership of your data, and then you have different means of setting up consents how to share your data. It could be health data, but it could be, well, any data, pictures you post on any of the social platforms or what have you. And these was initiatives from the Solid community are very much, in line with what you're doing from the My Data organization. And that was my question: is, are you, thinking in the line of thought of actually, using the Solid set of open standards as a back-end foundation for your My Data provisioning? Long question, sorry.
Yeah, I can answer that. See, at this moment of time, we have come out with a concept called a data operator that involve a lot of different components. Some of those components could actually be coming from Solid. Solid itself is not really fully mature yet. So what we are really doing is really bringing in certain what we call as proto operators. So we've actually tried and tested some techniques and coming out with a standardized way to do it. So the first attempt was pretty much to define those, so what is it that we're targeting? That's what we have done, proposing a concept called My Data Operator, and identifying the components that are essential for a human-centric, say, internet, essentially. We have been monitoring Solid, and we will continue monitoring, and we will also be adopting certain components that is provided by the Solid Foundation. We are also looking at things like Sovereign, which provide SSI components, and the Hyperledger projects in a way. So it's very much like up to the proto operators to really decide what exact technology to choose from. At the same time, what we are targeting is to really define the standards, adopting things like schema.org, and also endorsing that as like, this is the way that we are going to adopt. So we'll try our best not to really reinvent the wheel. We are pretty much, looking into reuse as much as possible. At the same time, really figuring out a way to actually make it possible as early as, say, 2021. So that's our target now.
Perfect. So
Yep.
then I have a question to Aaron. Aaron? Yeah, so my question to you, Aaron, was in the line of thought of using schema.org, and how, I mean, it's been getting quite wide adoption since 2008 when it was first started. In terms of as you had a case here with the reporting mechanisms and the metadata structures for doing that from the healthcare provisioning. How do you see the uptake from the healthcare community in the Americas? Because you were also referring to that you were the first one to ask the question was basically the American or the USA different agencies that have the CDC standard. Have you seen kind of the data is published according to the schema.org since this?
I've yet to see any representations of the data in the wild, so I'm not sure to which extent this is being used or if it is being used. I haven't heard of that. Often schema.org will put mechanisms in place to support the promulgation of certain different types of data, even if there's not especially a use case for it at the present time. And I think that was the case with the CDC tabular data. Let's provide this mechanism for publishers that might want to provide this data but don't have a mechanism to do so except through embedding it on web pages. So here you go. But to this point, I haven't heard of it being used. Doesn't mean that it's not very difficult in the web to see that. Harold, yeah, you had something.
Yeah, because actually, briefly speaking to the SOLID initiative, one of the things that underlies the SOLID initiative, at least getting some of the patient health data together, is the FHIR RDF model that is actually being baked into part of SOLID. The FHIR RDF model also we've published it without a huge amount of uptake as a schema.org model. To augment another schema.org model, the healthcare.schema.org, that actually is getting some interesting use. I'm not sure what the purpose is, but the Mayo Clinic and Johns Hopkins and others annotate their own medical information. If you want to know about diabetes or you want to know about something, they use the schema.org mechanism to augment their pages, and Google, a lot of the knowledge you get when you search for medical data on the Google homepage and other search engines as well, uses the same schema.org machinery that's being used for the marketing and the other aspects.
Yeah, the great points, Harold. The medical portion of the vocabulary previously under the subdomain that you mentioned and resides there, but they're all equivalent now, is one of the longest standing domain-specific portions of the vocabulary. And to your point, I think it's long been employed and has seen uptake because it is a method of providing that data in a structured format to Google, thus increasing the chances for webmasters that that information is going to appear, especially in knowledge panels. So it's a way of pushing that web-based information into Google's knowledge graph as a kind of a shortcut. Whereas the uptake for things like the CDC records, or even special announcement to a certain degree, although the use case for that is fairly well laid out, but in terms of things linked on there, like disease spread statistics, there isn't necessarily a well-articulated use case for how either the search engines or public, things like public health authorities would use that. And whenever there isn't a clear use case for schema.org data, it's like, you can use this, but we're not sure that we're going to do anything with it. If you do, then understandably uptake tends to be lower. So carrots always work well with schema.org data. If you do this, you will get this beneficial result.
Yeah, so leading back to Harold and also David, if you're still on the call, I see the whole list of in terms of, well, the use of HL7 and FHIR mechanisms for data exchange, and given the kind of the data propagation from different registries, national, regional, at the local hospital, to the kind of summing up national statistic that's shared is to the global meter, and well, which is shared in terms of the data. Do you see that the use of the FHIR protocol is, a useful mechanism to connect these, the different data sets and the provisioning of the data sets?
Well, your term FHIR protocol is interesting, because that's not the part that we need to leverage. Whenever we hit a situation like this, where it's a knowledge graph situation, we need to join things together from different domains and different databases that we haven't joined earlier. And that's where we all of a sudden have to start searching for shared semantics, shared identifiers, and what have you. One of the goals in getting this entered into FHIR is while people know how to search FHIR directly, it's also the fact that the RDF identifiers used in FHIR are at least documented and available to the rest of the community. So it was also put out in part as a means of getting the data into the knowledge graph, because anybody can take the columns in a spreadsheet and turn them into a knowledge graph that nobody else can understand unless you've documented your spreadsheet. Our hope was that by leveraging the FHIR model and the ancillary information, that we would have tags and anchor points that people could look up and understand in the FHIR space, and then use knowledge graph tools and RDF tools to link into other domains.
Brilliant response, Harold. And I think that is kind of the outcome from my knowledge now, been engaged in lots of different international conversations, is exactly that, how we semantically connect these different data sets, because there's our huge amount of data sets provisioned, as you said, with the example that David just shared with, well, thousands and thousands of new publications coming out, and new trials and what have you. And to be able to connect those and build a kind of a federated knowledge graph for this specific task of connecting the dots with known facts that we have about all the domains, that is kind of where we're getting at. We're over time now, and I wonder if there are any of the lovely people here in the audience who has not fallen asleep, because we're talking about metadata and RDF and other fascinating stuff, which we as data nerds really standards and that. So if there are any other questions from the audience, I'm happy to just raise your voice and state your question. I think there is a something here coming in. Yeah, well, yeah, so that was just, it was that. So if there's not more questions, I'm happy to say I wish you all happy Corona. I will send you a beautiful song to dance to while you go to bed. The Corona song made by the German choir. It's quite fun. And for all of you participants, happy to have you here. And for all you guys, Harold, David, Aaron, Lal, and Frederick, and obviously Lars, thank you very much. And I wish you a beautiful weekend.
Thank you.
Stay safe. Stay safe.
Stay
Your hands.
Bye, guys.
Keep the distance. Keep the distance.
Bye-bye.
Thank you.
Bye-bye.